Good evening, everybody. Welcome to Module 3 in this webinar series on advances in cardiovascular safety in the treatment of patients with prostate cancer. My name is Katie Zhang, and I'm a cardiologist practicing at Washington University in St. Louis in the United States. I'd like to thank Ferring, the EUA, the CUA, and ICOS for co-hosting this webinar session today. Hopefully all of you have had the opportunity to view the pre-recorded presentations that are posted online featuring my co-panelists that will really help to guide today's discussion. And at this point, I'd like to invite Dr. Merseburger and Dr. So to introduce themselves.
Well, Katie, thanks a lot, and everybody, welcome this pleasant evening here from Lübeck, northern Germany. My name is Axel Merseburger. I'm a urologist working also in uro-oncology. That's why I'm delighted seeing you, meeting you, and discussing the couple talks we had on cardiovascular safety and hormone therapy in prostate cancer. Looking forward to discuss within the next hour. Thanks.
Hi, Katie. Axel. Again, it's a real pleasure to be part of this panel. I just want to thank the EAU and again, on behalf of the CUA, as I'm a Canadian uro-oncologist in Vancouver, British Columbia, I'm happy to represent the CUA in this educational program.
Wonderful. And I'm here on behalf of the International Cardio-Oncology Association, ICOS. So thanks very much to everyone for inviting me to participate. So hopefully all of you are able to access the Q&A chat box. So I will be presenting a short case presentation to kick off this session, but really the bulk of the hour will be spent on discussion. So we invite all of you to enter in questions as they may come up. So now we will jump right into the case presentation. Hopefully you all can see my screen here. Here are my disclosures today. So this case is of a 72-year-old male who was referred to oncology with a rising PSA. He was initially diagnosed with high-risk prostate cancer about 3 years ago. And at that time, he had a Gleason score of 5 and 5, PSA of 17, and he underwent treatment with IMRT to the pelvis and prostate, as well as 2 years of leuprolide therapy. He responded quite well to this treatment with a very low PSA nadir. However, at this time, 3 years later, he's presenting with an elevated PSA of 2.7, concerning for recurrent prostate cancer. On oncology evaluation, he was sent for a PET scan, and he was found to have diffuse osseous uptake as well as lymph node uptake concerning for metastatic disease. And he did end up undergoing a bone biopsy, which confirmed metastatic prostate cancer. At this point, he was started on Lupron and abiraterone. However, he was endorsing shortness of breath, and because of this, he was referred to cardiology for an evaluation. At this point, I'd like to share his past medical history. As you can see, he has a number of cardiovascular risk factors: hypertension, prediabetes, hyperlipidemia. He's on a number of blood pressure medicines, including furosemide, a water pill, as well as gemfibrozil for high triglycerides. So at his cardiology evaluation, he was endorsing shortness of breath with minimal exertion. This had been worse over the last several weeks. However, he had really no other signs of heart failure or coronary ischemia. On physical examination, he had an elevated blood pressure of 145/74, normal pulse rate, normal oxygen saturation, and he was slightly overweight with a body weight of 77 kilograms. Because of these new symptoms of shortness of breath, he was sent on for an echocardiogram, and this showed normal left ventricular function. However, he did have moderate aortic stenosis and left atrial enlargement, which was concerning for increased intracardial pressure. He was also found to have moderate pulmonary hypertension with a right ventricular systolic pressure of 60. So all in all, this echocardiogram was quite suspicious for volume overload. He was also sent on for cardiac biomarkers. This included an NT-proBNP, which was very elevated, over 12,000, and this is consistent with a heart failure episode. He also had a lipid panel checked, which showed normal LDL and total cholesterol. However, it did show low HDL as well as increased triglycerides. And his hemoglobin A1C was also consistent with pre-diabetes, as was already known. Now, these were kind of the only cardiovascular testing that were done, but the cardiologist did look back at this patient's PET CT that was performed, just to look for any signs of coronary calcification that may have been seen on the CT portion of that scan. And as you can see here, this is the heart here, and you can see that there is a fair amount of calcification in the left anterior descending artery as well as the aorta here. And you can see again here, calcification in the LAD as well as in this diagonal branch, suggestive of severe underlying coronary artery disease. So based on all of these tests, the patient was increased on his furosemide dosage to aid with diuresis. He was also started on low-dose aspirin and rosuvastatin for primary cardiovascular prevention. And of course, he was continued on leuprolide and amiodarone for prostate cancer treatment. 2 months later, however, this patient did present to the hospital with shortness of breath. At this point, he was endorsing lower extremity edema, as well as chest pain with exertion and orthopnea, both of which are concerning for heart failure, as well as maybe coronary ischemia. His blood pressure was more elevated today, up to 167/87. He was tachycardic to 104, and he was now hypoxic, requiring 6 liters of nasal cannula. Of note, his weight was also increased up to 82 kilograms, suggestive of some volume overload from heart failure. His EKG now showed sinus tachycardia as well as these hyperacute T waves, again suggestive of an ongoing acute cardiac process. Again, some cardiac biomarkers were checked, and his NT-proBNP was further elevated, up from 12,000 to 20,000, again very consistent with an acute heart failure episode. And then he did have serial troponins checked as well, which were elevated. So the patient was treated with IV diuretics. However, he continued to have shortness of breath and chest pain, and so he was sent on for a coronary angiogram. The coronary angiogram showed severe one-vessel coronary artery disease, which you can see here kind of in the distal section of his right coronary artery. It did also confirm severe elevation of his intracardiac pressures, consistent with heart failure. Because of the severity of the heart failure episode, stenting to this stenosis of the coronary artery was deferred until he was more euvolemic. So in terms of the follow-up for this patient, he was discharged home after a period of IV diuresis. However, this was complicated by rise in creatinine from 2.1 up to 4.0. And around the same time period, he was found to have increase in his PSA from 2.7 all the way up to 39. Repeat imaging did also show widespread osseous metastases with pathological vertebral fractures. And so this patient did elect to transition to hospice care. So I think this case really brings together a lot of important kind of teaching points about cardiovascular care for our patients with prostate cancer receiving hormone therapy. Firstly, in any patient who's receiving anti-androgen therapy, all cardiovascular complaints require evaluation by a specialist. And I think, some providers may worry that they don't have a cardio-oncology specialist around or maybe don't have an academic cardiologist around to evaluate the patient. But I'd like to really emphasize today that these complaints that these patients or the cardiovascular events that these patients are prone to are really kind of bread and butter cardiology problems that any cardiovascular specialist is able to evaluate. So it could be a community cardiologist, an academic cardiologist, a cardio-oncologist, anybody will be able to help you manage these patients. And then finally, my second point, teaching point, is that cardiac biomarkers can be very helpful to risk stratify and guide treatment for these patients. So in this case, you saw that the NT-proBNP, the high sensitivity troponin, and the lipid panel were all helpful in adjusting medications and ultimately, guiding the inpatient hospital course for this patient. And then just finally, I'd like to mention that while the PET CTs are ordered for oncology purposes to assess for metastatic disease, for a cardiologist, they can be very useful if they do show coronary or aortic calcification, because it may indicate that that patient would be at higher risk for arterial vascular events and may benefit from more aggressive primary prevention. So that concludes the case presentation portion of today's discussion. And so at this point, I'd like to invite my panelists back, and we will open it up for discussion. So I have a comment here from Jeroen Fernando. Thank you very much for your question. So as per the recent CUA as expert opinion, those who have pre-existing cardiac history, it's better to start on GNRH. I guess the question is there a preference on starting patients with pre-existing cardiovascular disease on GNRH agonists or antagonists?
I can start on that. Thank you for the question. I was a member of that panel, and I think that it is obvious expert opinion. We don't have a clear-cut answer as to which is better for the heart, antagonist or agonist. I think there's definitely growing evidence. We do have the HERO trial, which some say directly or some say indirectly show the potential advantages of an antagonist versus an agonist. But even then, as you recall in my presentation, the evidence is not 100% clear-cut. On the other hand, it is a very simple thing to do. And again, it just requires a couple of things. One is the recognition of cardiac risk, and then number two, the initiation of the antagonist versus the agonist. So I agree with the question that it may have been more ideal to be on the antagonist. But again, the data isn't 100% clear-cut. And I'll just leave it at that. And Axel, I'm not sure what your opinion on that is.
Yes, first of all, Katie, thanks for this very clear-cut, great presentation. I have to pass when it comes to this cardiology expert knowledge. And so I think it's very good that we sit together here, the three of us, to discuss what the other doesn't know from their field. So I think that's also the intention of this webinar. So my question would be also, I mean, not only the ADT, but also the abiraterone. And as we know, abiraterone, when administered without glucocorticoids, this abiraterone acetate induces a syndrome of somehow secondary mineral corticoid excess due to this CYP17A1 17 alpha hydroxylase inhibition. So here it comes to a decreased glucocorticoid production. So in other words, simplify, the fluid exchange is altered by abiraterone. So that's why we need in primary metastatic disease prednisone 5 milligrams daily, and in mCRPC 2 times daily 5 milligrams. So my question would be, did he receive this medication, this co-medication? This would be my first question. And the other one would be, I would be a little bit cautious with giving abiraterone in those somehow cardiovascular affected men. I'm happy to hear your opinion and also Ellen's opinion on this. And then I think we should go in deeper this topic of which ADT to give, the blocker, the antagonist, or the agonist. Thank you.
Yeah, I agree. I think that may have been limitations of the timing of when this came about. As you know, the data for mCSPC first came out with the abiraterone. So again, it just might have been the timing of the situation, but I agree with you too that there are potentially greater cardiac effects associated with, as you mentioned, the prednisone and the suppression of the steroidogenesis cascade and the increased amount of ACTH as well as the prednisone use. That being said, I still think that there's also some data, and in your presentation, you very nicely elucidated this as well, is that even enzalutamide in combination with ADT can cause some potential secondary cardiac effects. So again, between a rock and a hard place, which one is better, I don't know for sure. But again, considerations of abiraterone, prednisone, as well as whether or not he even should have been on it in the first place. I think that's what you're alluding to. Is also an issue.
And
yes, the patient did receive co-treatment with the steroids, I obviously can't speak to the appropriateness of the abiraterone as a cardiologist, but I will say that we have noticed that a fair number of patients do have quite a robust hypertensive response to abiraterone and enzalutamide, and sometimes it could be quite refractory to antihypertensive therapy. So I would, as a cardio-oncologist, my goal is always to optimize cardiovascular therapy to allow for whatever cancer treatment is necessary to treat the patient's cancer. And so, I'd like to think that with very careful cardiovascular optimization, any cancer treatment that is deemed to be necessary it will be possible to administer. But I think, in this patient in particular, probably the heart failure should have been more carefully addressed and optimized prior to initiating probably the abiraterone to avoid the decompensated heart failure.
Yes, Katie, if I can comment here, I think this would be like a very good comment if I would receive this from you, being a cardiologist and with a special interest in oncology. So because then you would say, okay, this wouldn't be the best candidate for abiraterone. And as we know, Alan and myself, we have other options, for example, enzalutamide, which doesn't affect mineralocorticoid excess as much and doesn't have to be combined with prednisone or in mHSPC to use apalutamide nowadays. I think so. We have some other options which also have similar tumor efficacy like abiraterone. So I think this is very important to discuss. And I just saw one comment in the chat. Why not use radium-223? At least from European perspective here and in Germany, radium-223 is just approved post-doxycycline and only in bone disease with symptoms and not in metastatic otherwise prostate cancer. I mean, I think this was M1 as with regards to lymph nodes. And so I think I would be a little bit shy from indication-wise using radium-223 just to answer this question on a focal.
Thank you for addressing that question. There was another question, would abiraterone or enzalutamide be considered an absolute or relative contraindication in patients with significant underlying coronary heart disease? I think that's a really great question and really segues into, jives with what we've just been talking about. And like I said, I think that, I hate to say as a cardio-oncologist that any, important cancer therapy is contraindicated. I do think that, for a patient with significant coronary disease, a very thorough baseline cardiovascular evaluation and initiation of cardioprotective medications would be absolutely critical prior to initiating either abiraterone or enzalutamide. So I think in the patient case that was presented, if that patient had gotten the heart catheterization done prior to initiation, then we could have dealt with the coronary stenosis. We could have diuresed the patient significantly and gotten them more euvolemic. And at that point, I think it would have been very reasonable to try either one of those agents. Of course, if, enzalutamide doesn't require the prednisone and maybe has less of a volume overload concern, then I would probably recommend to the oncologist to try that one as opposed to abiraterone. So clearly there needs to be good lines of communication between the cardiovascular consultant and the oncologist. But I really don't never like to say that any cancer treatment is an absolute contraindication just because of a cardiovascular condition.
I think Katie raised a great point. I think the biggest issue that I see is just the identification of those cardiac risk and that patient that needs to be referred early. The problems that I see is that maybe just like in this case, that patients are started without any consideration of the cardiac side effects, and it's something that we really need to pay attention to. And I think that the question is excellent, because of the fact that these agents that we're using, as I discussed in my trial, in my presentation, are being used earlier and will be potentially there for years and years. So the effect on the heart can be significant, not even on the first year, but with year 3 and 4. You can imagine all that affects these side effects that potentially could occur. And again, getting that baseline risk is crucial so that we can identify those patients that will be referred to people like you, Katie. So I guess my question to you, Katie, is do you find that there's any useful tool or screening tests that we can use as urologists, these frontline treaters of ADT and even potentially these other novel androgen targeted therapies that you would recommend for us to use?
That is a really wonderful question. And I think it's tough for the urologists and the radiation oncologists because, you know, all these men with prostate cancer, they're older men. They're probably going to have hypertension or high cholesterol. They're probably former smokers or current smokers. So you could argue that really all of them should see, you know, a preventative cardiologist. You know, at the very least, I would say that anybody with a documented history of coronary artery disease should see, or a history of really any vascular disease, coronary artery disease, stroke, or peripheral vascular disease, should definitely see a cardiologist either at baseline or during treatment with antiandrogen therapy. And actually, this is a perfect segue into, I'm actually working on a project with Daryl Leung, also in Canada. He's a cardiologist, also very interested in this prostate cancer space, and he's done really great work characterizing the cardiovascular risk of men with prostate cancer. And it turns out that these men tend to be at quite high cardiovascular risk, just based on the Framingham risk score. But the idea that we would like to move forward now is to actually develop a screening tool specifically for men with prostate cancer, just like you're saying, that can be easily applied in the clinic by urologists, or potentially even by patients to say, you know, am I at significantly increased risk? And then maybe I need to be referred to see a cardiologist. So you know, maybe there's more to come on that, a tool like that in the future. But for now, I would say, you know, anybody with a documented history of arterial vascular disease should definitely be referred, but really anybody with cardiovascular symptoms should be referred. But I really think that it is reasonable to really refer any man with any cardiovascular risk factors. So, you know, that might be a lot of people, but I think it would really be great for patient care.
I can only echo here. And when I have my outpatient clinic, I have two business cards in my pocket. The one is from the cardiologist, which by coincidence uses the room any other day, so he always has some cards probably prepared for me. And the neurologist, because I think those are when you ask me what are the long-term effects on ADT, I think it's on the one hand what we're touching today, the cardiovascular events, and that we treat men within their 70s, even though most of them think it's like in the middle of their life, like half-life and another 50 years to go. It's probably not. And most of the men have life expectancy of about 10 years, if not less. And so second cause of death aside the prostate cancer is cardiovascular events, which we covered in our talks as well. So I think it's very, very important to have an early connection to the cardio-oncologist, and on the other hand, a neurologist, because we know long-term effect can also be like dementia and neuro problems. So I think cognitive function should be also kept. Best would be to combine both, like having an interdisciplinary prostate checkup, one-stop shop thing.
Yes, that would be ideal for sure. just to reiterate, there was a question about whether all elderly patients with prostate cancer need to be seen by a cardiologist. So I think in an ideal world, the answer would be yes, but I think in a world with limited resources, again, anyone with known arterial vascular disease and anyone with cardiovascular symptoms should certainly be evaluated. There are a number of questions in here about the PRONOUNCE study, so maybe we can just jump right into that. I can again share my slides so we can have a little bit to work off of. As everyone knows, the PRONOUNCE results just came out very recently, and so we're all just kind of getting used to the
very well-informed participants. They must follow us on Twitter because it's on a circulation conference and just out yesterday, the PRONOUNCE trial.
Yes, or Axel or Alan.
Yes, so I think, everybody somehow, there was like some existing evidence, phase 2 evidence that degarelix, the only blocker available right now, and relugolix, the oral compound, is better with regards to Macys myocardial infarct and some cardiac events. And we've seen phase 2 evidence and then phase 3 evidence of the HERO trial, really showing superiority of relugolix, the oral, not yet in Europe available GNRH antagonist. And this somehow leads to the question, and this trial was initiated some years ago, if this is the same for degarelix versus Lupron. And here we have the long-awaited PRONOUNCE randomized trial. And this was like an international multi-center prospective, well-designed trial, one-to-one randomization with a man. And we don't have the full publication as of yet, just a YouTube contribution you will find on YouTube on the presentation and this abstract here shown by Dr. Zhang right now. And the main bottleneck of this whole trial is that it was underpowered and didn't recruit as well. So out of 900 planned, pre-planned and statistically calculated men, ended up to be 545. And numbers-wise, 15 men assigned to degarelix had a Macys, compared to 11 assigned to Lupron. So 5.5, 4.1. So it wasn't really a signal. But I'm curious to hear your opinion, Alan. And I think it's very hard to speculate what we would have seen if this trial fully recruited in a timely manner. Also, I think we should touch on the inclusion criteria. The cohort is slightly different than the HERO trial.
Yeah, so thanks for that. The trial obviously is disappointing, but not surprising in terms of its results, in that it ended so quickly. We were a trial site, and just like most trial sites had difficulty with accrual, and just like you're inferring, one of the major issues was the fact that they had to have some sort of cardiovascular event about 6 months, or actually it was 12 months prior to the time of randomization. So these were the most sick of those with cardiovascular issues. And as such, just like you've mentioned, the number of men, I think there was only 60% of the total planned accrual actually got in. And I think that's the biggest limitation. And I'm sure the authors and us, public, who are not part of the authorship, knew that the results would have significant limitations. But I think we can look at the data somewhat and just look at the small numbers. And unfortunately, we're not seeing a huge difference. But again, the explanation is likely due to the fact that even in this high-risk patient population, the number of events were quite small. And again, we don't have the paper, but potential theories that I can come up with, maybe that these patients were started on a second type of androgen targeted therapy early, and thus were not part of the study, or they had other issues that allowed that unfortunately could force them out of the study, whatever the event, whatever happened, the total number of events were very, very small. So it's hard to conclude anything from the results of this trial, unfortunately. And again, it's just a testament to the fact that we really have to ensure that when we have great trials like this, that we try to enroll as many people as possible in order to get an answer. And unfortunately, we don't have that quite clearly here.
And just to build on your comment about the low cardiovascular event rate, I think it's really also important to highlight that both arms of the trial, in both arms, patients were required to be followed by a cardiologist for optimization of their cardiovascular risk factors. And I would say that that is very much not standard of care for men with prostate cancer. So, you know, potentially that also reduced kind of the power of the study because the cardiovascular outcomes were going to be quite good in the control arm as well. I think in real life, I frequently will get prostate cancer referrals and men are still smoking and no one's checked their cholesterol in 10 years and, you know, their blood pressure is through the roof and the primary care physician just can't quite get it under control. So these are very basic things that a cardiologist does very automatically that I think probably made quite a big difference for the men enrolled in this trial. So I think it also just speaks to the importance of having a cardiologist involved in the care for these men to overall improve outcomes. And potentially it may not matter which type of ADT you use if you have a cardiologist involved, maybe, because we don't know.
Well, Katie, thanks for really pointing this out, because I think this is one of the probably most clinically relevant aspects of this trial compared to the HERO trial. And when we look at the numbers, it was a difference, Macys Lupron compared to relogorelix, 2.8%. So it wasn't really like years we win there. But I think taken together, I think it's good that this somehow glues our disciplines together, that we work together, that we think of this. And I think this is my main take home from those trials, even though this one was underpowered, that we should collaborate. And as you said, probably your discipline really helped a lot of men in this trial by setting their blood pressure to a regular level and getting them like fit for the therapy that is upcoming. I just found, sorry to interrupt your moderation, but it's a recent colleague of mine, a dear friend from Dr. Matzdak from Hannover Medical School. I think he had raised an important point here. This is what our residents also asking once in a while. Do we need prophylactic anticoagulation therapy or aspirin? Does it make sense in an ADT scenario in general? I think this question is really smart.
Yes, thank you for bringing up that question. That's a great question. And you know, there's obviously this is a data-free zone, and I think there's a great opportunity for, you know, clinical research in this space, collaboration again between urologists and cardiologists to answer this question. But I guess from my perspective, I think I would have a very low threshold to put all men on ADT, on a baby aspirin and a statin. I think those are very basic primary prevention cardiology tools that we have, and I would say that any man on ADT would be at increased risk for a cardiovascular event. And so if there's no problems with GI bleeding or such, you know, I kind of am very liberal about recommending those, again, without great data. In terms of actual anticoagulation, there's some interesting literature in the general cardiology literature these days. The COMPASS trial actually showed that low-dose Xarelto helped to reduce the incidence of adverse cardiovascular events in people with coronary artery disease, as well as in peripheral arterial disease, when added to low-dose aspirin. And so now, you know, we don't do it for everybody, but for my general cardiology patients who have coronary disease or peripheral vascular disease, I will sometimes add low-dose Xarelto because this trial did show a reduction in adverse cardiovascular events. So, you know, I've actually been wondering for some time now if maybe these men who are getting ADT for prostate cancer should also be recommended for low-dose Xarelto. Precisely for this reason, you know, I'm not going to do that clinically until I see some data, but that is a question that I'm very interested in pursuing.
Katie, while we're waiting, you mentioned some of those biomarkers would you recommend any kind of testing that a urologist would order prior to sending them to you, or just try to get a grasp as to cardiac health? Like, would you recommend just getting a BNP, ordering an echo, or doing anything else to try to establish a baseline risk?
Yeah, that's a great question. There was another question in the chat about a baseline echo. I think the issue, I know, urologists are all really busy, and when you order a test, you have to follow up on the test and figure out what to do about it. So, I think the most reasonable thing to ask a urologist to order would be a lipid panel, because I think that's a really important risk stratification tool for us in cardiology for, Framingham risk, calculations. And I think you could always, refer the patient back to their primary care physician to actually start a statin or whatever might be appropriate, so that you as the urologist are not responsible for that. So I think that a lipid panel for everybody getting ADT would be very reasonable. In terms of the echo, I think that's a difficult question because there's so many unnecessary echoes that are ordered in the world. So, I think for any patients who's having cardiac symptoms, chest pain, shortness of breath, I think that an echo and or an NT-proBNP would be very reasonable. But, I really wouldn't expect a urologist to be following up on those test results. And so I think, from a practical perspective, probably that would go hand in hand with the cardiology referral. So, the NT-proBNP, the echo, and the troponin, and the lipid panel are the three things that I think would be most useful.
Do you have like guidelines on exercise or diet? This is sometimes the patients ask us, what can we do? Sure, sport is always pretty good, but here, is there any recommendation from your society on what to do and what maybe not to eat? Or
yeah, this is such a great question. And again, this is part of the personalized tool that I was talking about earlier that Daryl Leong is working on. We want to be able to assemble all of these cardiology guidelines and package it in a way that urologists can easily, interpret for their patients. But for my patients with prostate cancer on ADT, I barely just go over the basic American Heart Association guidelines on diet and exercise. The AHA recommends 30 minutes a day, 5 days a week of exercise, and really could be moderate intensity. I tell patients you don't have to go to the gym, you don't have to be running. It could just be a fast walk, something just to get your heart rate up. And then I think diet is so important, not only for cardiovascular health, but also to help with weight loss. A lot of these men are, a little bit overweight or even obese. And so the American Heart Association, they kind of talk about a dinner plate, and the dinner plate should be half vegetable, a quarter meat, and a quarter starch, to be a heart healthy diet. So I really talk to my patients a lot about a diet high in fruits and vegetables, lower in fried foods and fatty foods. I know the American diet's a little different than the European diet, but also portion control to help with weight loss. And then finally, I'll add that really smoking cessation is so critical for these men, because a lot of them, as I said, are still smoking, and that is such a hard for the patient, but an easy intervention for the doctor to just say, I think that if you quit smoking, that could really reduce your chance of having a heart attack on this treatment. So those three things, those are the main things that I talk to my patients about.
Thanks. Like especially smoking makes the urologist very happy, reduces the risk of bladder cancer, but there's another topic. So food-wise, we can agree on a sushi California roll. This is a good mixture. Yep. And exercise-wise, just follow us in clinic, running around all day. Sure. No, just kidding. Perfect.
There's a question in here from Joseph Marensek. What proportion of men with prostate cancer are at high cardiovascular risk? So again, I'll refer to the work by Daryl Leong, again, and from Canada. He's a cardiologist. They conducted this observational study called RADICAL-PC, where they prospectively enrolled men with prostate cancer that were newly diagnosed. And they found, I think this was amongst almost 2,500 men, that 2/3 were at high cardiovascular risk based on the Framingham risk score. And I'm just reading here, there were 22% with known cardiovascular disease, 20% had diabetes, 45% had hypertension, and then 31% had obesity. So it's really quite a large proportion of men that we're talking about that are high cardiovascular risk. And so again, I think that general primary prevention strategies would be very important prior to starting on ADT. So let's see. I guess Axel, there's a question from Dr. Motla about relugolix. Is there any evidence regarding relugolix? I know we were just talking about degarelix in relation to the PRONOUNCE study.
Yes, the dear colleague from Vienna should definitely know, since he just published like a network meta-analysis on those two randomized trials, degarelix and relugolix, and it's published in European Urology, I think just very recently, July this year, and just concluding that efficacy and safety of relugolix, pretty hard to pronounce for German, are very comparable to those of degarelix. Just different mode of action, where for degarelix you have this injection site reaction. Since it's a subcutaneous injection, we have maybe the limitations with regards to compliance and adherence in the oral blocker formulation. And within the trial, this was pretty tricky. You had basically a Riffit tablet box. When you open it, it just sends out a signal. So the monitor knows exactly if the patient or not used it every day. And this is not like in daily clinical practice. So you don't know. And as we know, and you much better being an internal medicine expert and cardiologist, how often do the patients miss their oral medications compared to the one we just give by syringe by the medical oncologist or urologist. So I think there are differences. Those trials cannot be compared. I think the colleague from Vienna did a great job in having this meta-analysis, network meta-analysis, but it's not head-to-head. It's different populations. It's different drugs. But I think coming back to the question, and we should catch up with Ellen there as well, and yourself, is there a role of degarelix with regards to those men with the pre-existing cardiovascular disease and the need for ADT? And I think, yes, there is. Looking at the HERO trial, looking at other evidence, and also some basic research that like the platelets maybe don't stick as, but you would be the expert to explain this, but as pronounced as in other ADT formulations. But I think, again, indication has to be wise. Not all the men needed ADT historically. We did some overtreatment years ago, and now this is better regulated by better evidence out of the guidelines from the societies we are presenting here. So I think it's really, is this a question that you get from your urologist or oncologist? Should we use an antagonist, or can we use 3-monthly agonist formulation? Like, do you advise and say, okay, no, better give degarelix in this pre-existing heart disease, or is this a question you never get faced with?
You know, it's interesting. no one really asks me for my opinion on that. They kind of just do what they want, which I actually think that's okay. I mean, I don't want to be the oncologist. So I think if there's a very strong oncology reason to choose one over the other, you know, I would want to facilitate that option as much as possible. You know, I think, like I said, I think if I can optimally revascularize a patient's coronary stenosis or diurese patient and get them, you know, to a good cardiovascular point, then I would want to be able to get them whichever treatment option the oncologist thought was most appropriate. You know, I think, you know, as we've been discussing, I think that the jury's still a little bit out on the antagonist versus the GNRH agonists. So, you know, I don't really want to be providing a firm opinion on that yet, but I do think that all, you know, with optimization of cardiovascular risk factors is an absolute must prior to starting either of them. And I kind of leave the actual agent selection up to the oncologist.
Yeah, I mean, I agree. I think that, you know, there's absolutely no data that one is better from an oncologic point of view, there are definite convenience factors, the 1 month versus 3 month. But I'll tell you practically, what I do is, without a doubt, if there are cardiac risk factors, I take all the data that we know, and it does seem that the antagonists appear to be better. Sorry, the antagonists appear to be better than agonists. So I will definitely tend to use the GNRH as Relugolix is not available. But I agree completely with Katie that the jury is still out as to the true difference in terms of cardiac risk. But if you have that patient with risk factors, why not give them one that could be better, especially because oncologically they're very similar and are very efficacious. And again, all else being equal, I will probably choose the GNRH in those with cardiovascular risk factors. The problem is just reminding yourself, obviously, and identifying risk factors in those patients that you have.
Great, so we have about 15 minutes left. So again, feel free to enter more questions. We have a few here we have not addressed yet. Harun Fernando was asking about the patient in the case. Would he be better candidate for coronary revascularization as opposed to angioplasty? And absolutely, I can't even think the last time a patient only got angioplasty. Certainly coronary revascularization would be indicated. And I think a kind of a more common clinical question that frequently arises for these patients is, whether we recommend a CABG, coronary bypass surgery, or if we recommend a coronary stent. And, this especially becomes important for patients who are maybe metastatic and getting docetaxel. You have to correct me if I'm wrong. I think some of those patients do get thrombocytopenic, and that becomes very challenging to deal with a patient with coronary disease and thrombocytopenia, because then we cannot put them on Plavix after their heart stent. And so in cardio-oncology, we've actually gotten quite comfortable with referring patients with metastatic cancer for bypass surgery if they have really, really severe coronary disease, because as long as they can make it through the bypass surgery, then we don't have to worry about thrombocytopenia on cancer treatment. And so they can then go on to get whatever type of chemotherapy is necessary for cancer treatment. But absolutely, I would always advocate for coronary revascularization as opposed to just angioplasty. And then there's another question from Lice Roris. Sorry for mispronouncing your name. In case of HFpEF and use of anti-androgen therapy, would you start empagliflozin to optimize cardioprotection? Yes, absolutely. There's really great new data coming out about the SGLT2 inhibitors, which are kind of a newer type of diabetes medicine that promotes urinary excretion of glucose. And it shows that, patients with a large variety of heart disease, including heart failure, actually have better cardiac outcomes on these SGLT2 inhibitors. And so I absolutely agree that any patient with prostate cancer and HFpEF and diabetes should certainly be on empagliflozin or an equivalent medicine to promote cardioprotection. Absolutely. Okay, and then there's another question about orchiectomy versus medical ADT for cardiovascular health. To be honest, I haven't seen a lot of patients in clinical practice who've undergone orchiectomy, and I believe that Alan actually had Alan had a slide in his presentation about this issue. Do you want to talk more about that?
Yeah, I think there's definitely evidence from population data to suggest that men who've had castration had the highest relative risk of cardiovascular disease. But the theory is that it's not necessarily the type of castration, either surgical versus medical. It's just that those men are probably the ones that had the longest time of androgen deprivation. That being said, these are the men who would probably have the highest levels of FSH. And as you know, that's one of the leading causes of plaque loss of integrity is just the high levels of FSH. So again, I still think that there's a great role for orchiectomy. I take the population data, again, with a grain of salt because of the fact that these are probably men who have the longest amount of time on androgen deprivation therapy. And I don't consider that a contraindication in terms of cardiovascular risk to have a surgical or castration.
Axel, do you have an opinion on this?
Yeah, it's very, very rarely performed here in our region or Germany. It's maybe a cost issue sometimes where you choose for orchiectomy to save cost of medical castration. Limitations is surely that it's irreversible. It cannot be treated intermittent in case the patient refuses or doesn't like side effects. It's really tough. I mean, you could substitute testosterone again, but it's complicated and then costly again. So we don't really have a lot of men asking for alternative to medical castration and orchiectomy. I think with regards to cardiovascular health, Alan already summarized nicely all the aspects that are important and the evidence we have. So I think it is not really what we do on a regular basis. And I think it accounts, as said, for the longest period of treatment, and then again for the longest risk of ADT-associated complications. And this is what we see since we do treatment intensification upfront with, for example, apalutamide and ADT at beginning of mHSPC or even in M0 CRPC, so non-visible disease. We intensified with ADT and, for example, darolutamide or enzalutamide or apalutamide. This really prolongs the time on ADT and definitely opens up more opportunities for our collaboration. And I think it is important and to check upfront, because I think, and this is maybe a question for you, Katie, do you always see that a man, or can you rely on medical history, or can you say, okay, a slim looking, fit looking gentleman with no medication should not undergo check? So I'm not quite sure, because I think those are the ones that somehow get surprised by cardiac disease or heart attack, that you say, hey, he looked very fit, but at the end had an event.
Yes, and I think this, I think it's so hard for you, the urologist to try and cover all of this in your clinic because you're focused on the cancer. But, in my clinic, I kind of rely on, it's a multifaceted evaluation to assess cardiovascular risk. So, asking about cardiovascular symptoms, chest pain, shortness of breath, lower extremity swelling. I actually ask all my patients what their physical activity level is, because if they're telling me that they're going to the gym every day and they're biking, I'm not really worried too much about them. But if they're more sedentary, then I'm a little more concerned. And then in terms of history, the other really important thing is asking about family history. If they have a family history of premature coronary disease, then my red flags are up again. Smoking history as well. So, again, this is more than I would expect a urologist to talk about in their clinic visit. But, all these things kind of play into your risk assessment. And then, of course, the biomarkers, like we talked about, are also can be very useful. And then there was another question from Utsav Shah about the dose of prednisone in patients with heart disease. And I would say that heart disease shouldn't be a limitation in whatever dose of prednisone is required, but those patients who have heart failure should really be monitored for signs of volume overload. And you probably would want collaboration with the cardiologist to help you with that.
I think this was really important because with all chemotherapy, we combine with some corticosteroids and also with abiraterone, and we have some alternatives that are oncologically comparable with efficacy-wise. So I think this is also important to exchange knowledge here, and I definitely also like your comment on less thrombocytes in chemotherapy, that this is somehow associated with more cardiovascular disease problems. I wasn't aware of this. This was my biggest take-home learning here. And I think it's important to underline this and just echo you what you said.
Yes, thank you so much for highlighting that again. And it's very interesting because I guess as a cardiologist, so much of the treatments that I have to offer require a normal platelet count. If you think about atrial fibrillation, anticoagulation, coronary disease, and stenting, all of that requires a normal platelet count. So, I think a lot of cardiologists don't like the cancer patients because we can't do a lot of what we would normally do for patients because of the platelets. But to me, I think it just presents more of a challenge, and you have to kind of think outside of the box. So yes, that does present a complication from many perspectives. And then Ramzi Mejri, I guess this could be one of our last questions. Is there a checkup to be carried out before starting treatment with GNRH analogues? Yes. So I think the most important thing is to do a cardiovascular risk assessment for your patients. So I think at the very least, reviewing their medical problem list and seeing if there's any history of heart disease, especially coronary disease, stroke, peripheral vascular disease. And I would say if any patient has any of those problems, they should definitely be seen by a cardiologist before starting on ADT. The other kind of definite cardiology referral is if someone's having any sort of cardiac symptoms, chest pain, shortness of breath. I would say that those patients should really be evaluated to make sure it's not a big heart problem before starting on GNRH analogues. From outside of that, I think there is probably a subset of patients that would benefit. But like I've been saying, I think it would require more of like a cardiology, evaluation, like a full clinical assessment, biomarkers. So, if you feel up to it, you could ask about family history of CAD. You could check a lipid panel to check for high cholesterol, and if any of those types of things are abnormal, then you could refer to cardiology. But at a bare minimum, like I said, arterial vascular disease or cardiac symptoms should definitely be seen by a cardiologist before starting on those medications. Okay, so I think we are approaching the end of our hour. Axel or Alan, do you have any concluding comments?
No, thanks. I think your presence here just reiterates the importance of the collaborative approach to men with ADT. And we often collaborate with medical oncologists in North America. But again, bringing in a neurologist and a cardiologist, as Axel said, are just crucial. And I don't think you should try to do everything yourself. And the point is obviously trying to get help with other specialists to try to maximize the outcomes of your patients.
Yes, also thanks from my side. And it was really a pleasure. And I'm surprised how fast the time flew by and that we get some questions and very smart questions. Thank you to the audience. And as said, it's available, I think, within the next couple of days on the EAU YouTube channel and on EAU Web and also the other societies. So it was a pleasure working with you, Katie, and with you, Alan, and really looking forward to meeting face-to-face again in the future when the pandemic hopefully eases out somehow. Meanwhile, stay safe and thanks a lot.
Yes, thank you both. I really enjoyed this hour as well. So in closing, I'd also like to thank Fairing, the EAU, the CUA, and ICOS as well for hosting this webinar series. And of course, thanks to the audience for your excellent questions and for stimulating this discussion. So until next time, bye.
Bye-bye. Take care.